Regarding management, the decision making can be assessed by a good history. Decision making is helped by age, level of sports activity, uh, motivation, and the season of a game. Most important factor is the age. You can calculate, and the lower age there is more chance of dislocation. Rotator cuff problems are more common in the older age population, which needs to be addressed. Regarding shoulder, there is a injury severity score which quantify, it's called injury severity index, which helps is based on a preoperative questionnaire. In it consists of age, sex, age, sports, uh, age, sports, laxity, glenoid loss, and external rotation. A score of less than 6 points a risk of recurrence of 10% with arthroscopic stabilization. A score of more than 6 points, risk of recurrence 70%, and open surgery more appropriate. Epileptic patients should have at least 6 months seizures free before considering for surgery. If recurrent dislocation, we can do depending on what we find on MRI. Open repair is indicated if there is a bony defect or Hugel, that is humeral avulsion of glenohumeral ligament, or a Hill sac lesion. Arthroscopy causes less soft tissue injury. We prepare the glenoid and take an anchor from at least 3 anchors of less than 3.5 millimeter at 45 degrees. The anchors are placed at 3 to 6 o'clock in the right side and 6 to 9 o'clock in the left shoulder, and they are supplemented by capsular plication. If there is a bony issue, a Bristow sort of procedure, which is coracoid transfer into with conjoined tendon to add inferior glenoid defect. Letter J procedure is possible. It's a coracoid is passed through the split in the proximal 1/3 of subscapularis. Provides a triple effect. Letter J triple effect is type 1 is bony by increasing the glenoid surface area. 2 is conjoined tendon through the subscap, works as a dynamic stabilizer. 3 is capsular reconstruction. Overall complication 15 to 30%. Regarding previous historical, there is a putty plat where there is a double breasting of subscapularis and medial advances of capsule, cause early osteoarthritis and uneven stress in glenoid. Regarding if there is a Hill sac lesion, Hill sac and lesion and anterior dislocation is posterolateral. Forceful impaction of humeral head against the anterior inferior glenoid when shoulder dislocates anteriorly. Pathognomic of dislocation. The X-ray which is used for this is Stryker notch view. It helps to identify the Hill sac. There is a concept of engaging Hill sac. Engaging Hill sac means contact with glenoid in less than 4 degrees of external rotation. This quotes that there is a lever arm, small lever arm, and this can redislocate quite easily and needs bone grafting. Best view is Stryker notch view, and management is transfer infraspinatus with portion of greater tuberosity into the defect. The rim dressage technique with the posterior capsule and infraspinatus tendon sutured into the Hill sac tendon is an option